there's a growing appreciation that for patients receiving BRAF plus MEK inhibition, that the urban legend that every patient who got BRAF-MEK inhibition frontline was going to relapse and ultimately die of melanoma is not true. There is definitely a plateau on the survival curve as we now have longer-term survival from the early BRAF-MEK studies, the BRIM-7 study, the original so-called 220 dabrafenib-trametinib trial, and in frontline and even second-line patients, there's about a 35% plateau of survival 3 to 4 years, and it looks like it's going to stay there, implying some patients, especially those with a low disease burden, low LDH, few sites of disease, not having brain metastases, may do very well. And as Mike Atkins pointed out in his Crossfire talk with me, he correctly stated that 5 years ago the thought was that BRAF-MEK was only for the patients with rapidly progressive disease, and you would never give anything but immunotherapy to a person with a low disease burden. Actually, it's still pretty much you would easily treat a high disease burden, rapidly progressive patient with BRAF-MEK inhibition if they were mutated. But now the realization is, well, Ipi-Nivo or Ipi-Pembro could also do very well frontline in the rapid progressor. But what's really new is the realization that the biomarker for the success of combined BRAF-MEK inhibition is actually the seat of the pants, old-fashioned clinical low LDH, low disease burden, lack of brain metastases, which probably reflects a population of patients that are immunologically responsive. Much of the effect of BRAF-MEK may be immunologic, so at the end of the day, almost everything is about the immune system, as we say, as immune chauvinists, but it would suggest those patients might do very well with just BRAF-MEK inhibition. Most patients in the US frontline are still getting immunotherapy, but it would sort of allow us to expand our horizons. And I think the other important point is that you can safely combine BRAF-MEK and immunotherapy with a PD-1 inhibitor. And the preliminary, very early data are that those patients do very well. There is not even additive toxicity. It is certainly not synergistic like it was with ipilimumab and BRAF inhibition. And that would suggest there should be large randomized trials of those patients of BRAF plus MEK plus, say, PD-1 inhibition versus PD-1 inhibition alone. And the only question I have is, do you need a three-way trial? Do you need BRAF-MEK plus immunotherapy versus immunotherapy alone versus BRAF-MEK alone? That's a pretty big, expensive trial. But those are trials that need to be done, because I think the future is that you may take advantage of that priming, that immunologic priming with BRAF-MEK, followed by immunotherapy for sort of the longer-term survival plateau.